All right, next I'd like to introduce Dr. Crystal Mackall. Dr. Mackall is a professor of pediatrics and internal medicine who came to Stanford in 2016 after a 27-year tenure at the NCI. She is the founding director of the Stanford Center for Cell Therapy, leader of the Cancer Immunotherapy Program, and director of the Parker Institute for Cancer Immunotherapy at Stanford. Dr. Mackall leads an internationally recognized translational research program focused on immune oncology and has led numerous first-in-human, first-in-child clinical trials. It is my privilege to introduce her and look forward to hearing about her groundbreaking work with CAR T therapy.
Thank you. Nice to meet new people. Jonathan, it's great to be here and speak at this symposium in your honor. When you arrive on campus and you're, surrounded by strangers, certain people go out of their way to really make you feel at home, be interested in your work, and inspire you and get inspired by what you're doing. And Jonathan was one of those people. I think everybody probably has that experience with him. He's obviously a legend scientifically and clinically, but beyond that, he's really a great human. So it's been my pleasure to get to know you and work with you. So. Okay. There's some disclosures there. None are related to what I'll be talking about today, and I'll save some time because Oliver showed a similar, slide. Suffice it to say that CAR T cells kind of came on the scene against all odds. I mean, the notion that you could even commercialize a cell therapy, a living therapy, for many years, the field thought, yeah, well, it might work, but how in the world would you ever commercialize it? And we had the first approval back in 2017, and now, here we are, 16 FDA approvals later. As Oliver said, most are for liquid tumors, B-cell malignancies and myeloma. But while the two lifileucel and afami-cel aren't CAR T cells, they are cell therapies for solids. So we're starting to see that, solid tumors are approachable with cell therapy, but we still have so much more work to do. And I think, you saw from Oliver's experience and our experience with the ovarian, there are a lot of challenges, but it is our belief that we're still at the relatively low point on the impact curve. And why? Why are we so optimistic when, it's been, 15 years since the first signal of activity, and we still don't have a CAR that has very clear activity and safety in solids? Well, it's because so far, the versions of these cells that have gone into the clinic and are being tested, and the B7H3 CAR is no different, represent what we call version 1 engineering. These are the kind of the first structures out of the gate. And since that time, there's just been a dizzying array of advances in the ways that you can engineer these cells and deliver them. In fact, part of the problem in our field is we have so many ways to make these cells more potent, we don't really know which one of these to choose. You can't test them all in clinical trials, but suffice it to say, there's a lot of ways, there are many ways in which we can try to make these cells safer and more effective. And that's what we're going to talk to you about a bit today. But just to step back, again, Oliver, thank you for introducing the center. We know there's so much scientific expertise and the innovative technology and amazing clinical care at Stanford. We really believed it was the fertile place to build such an entity. And it is our hope and belief that we will move the field forward, for instance, deliver effective cell therapies for cancer. And just to give you an idea that we're treating large numbers of patients, this is a bit outdated, but we're probably up to 1,400 patients here at Stanford having received CAR T cell therapies. They come in, industry-sponsored trials, standard of care, but also the importance of research, and especially in this arena where we're still learning so much. You can see there on the right, the clinical trials that we're doing are about half or almost 2/3 investigator-initiated trials. So it's really about leveraging what's happening in the fundamental laboratories, that candy store that Carolyn was talking about, to come up with some bright ideas to solve the problems. And we know that the track these things have to go on is the virtuous cycle of translational medicine, where you take fundamental research, you take an idea, you convert that idea into a therapeutic that is suitable for testing in patients. You build a regulatory program so that you do this using the highest of quality standards according to all of the FDA mandates. You treat your patients with good clinicians, outstanding clinicians who watch them like a hawk and learn from the patients, and then you study the patients, and then the cycle starts again. And, to point out that we've just got such a fertile environment for this basic science here and new ideas coming down the pike all the time. Oliver also highlighted the work at the GMP facility over on California Avenue, led by Steve Feldman and Ramya Tanagantla. We really have state-of-the-art manufacturing there. You name it, we can do it. And so it means that even if we come up with a very complex car design in the laboratory, we have a very good chance of being able to take that from a research scale and using all of the standards required of good manufacturing practice and get that into the clinic. And it's a very unusual, there aren't many institutions in the world that have that capacity. And then having all the clinical faculty that, again, are going to care for the patients, really try to understand what's happening across disciplines. And that's why this is a center and not, a department. This is touching departments across campus, everything from neurology, neuro-oncology, obstetrics and gynecology, hematology, pediatrics, you name it, because cell therapy has a potential in such a wide array of diseases. And then, of course, learning from every patient. So this problem of solid tumors, we know what the barriers are, and they're not just one thing. One of the big barriers is we don't really have great targets. CD19 in B-cell malignancies is a great target. Every one of the cancer cells has the CD19. The only normal cell that has it is your B cell, and you can afford, the patient can survive and even, do well if we wipe out their B cells for a period of time. But most of the targets on the solid cancers, they're not as expressed at such high levels, or if they are, they're on a normal vital tissue. So first off, we have a challenge finding good targets. And Oliver mentioned this. It's not that B7H3 is totally absent on normal tissue. It's just that it's expressed at lower levels than on the tumor. So we have to try to be clever enough to thread that therapeutic window. We have trouble getting trafficking to the tumor. This is why we're so excited about the intraperitoneal delivery. Maybe that can really give us a leg up on that therapeutic window. And then, of course, we know that the tumors, when they, different than liquid tumors, when they create these masses, create a shield around them. Everything from the glycocalyx that Carolyn talked about today to myeloid suppressor cells and, you name it, the ways in which they can resist are manyfold. And so what we have to do is create something that's stronger, more potent to go after the solids, but we have poorer targets. And we have to do that while minimizing toxicity. So it's a really challenging problem. And the toxicity comes in mainly two flavors. One is going after a cell that expresses B7H3 that you can't afford to lose, or the off-target toxicity that Oliver talked about, the cytokine release syndrome and the HLH syndrome. So we have an approach that we're excited about that we think is reasonable to test that may allow us to thread a therapeutic window. And this was the brainchild of Louis Labagne, a very talented bioengineering grad student who stayed on to do some postdoc in my lab. And what Louis wanted to do was to figure out a way to regulate remotely, to remote control the car. And so basically have a car at baseline that was incapacitated, but if we give the patient a pill, we can turn that CAR on. And so then the physician can decide when to drive the CAR expansion and when to turn the CAR expansion off. So simply a remote control CAR. And he did this by employing a protease derived from the hepatitis C virus, so-called NS3 protease. And this thing is chopping all the time as long as it finds a motif. And so he incorporated the motif into the CAR itself to chop off the signaling domain. And he called it the snip CAR because it's always, snipping the CAR in half. So at baseline, the snip CAR is incapacitated, but if you treat with a hepatitis C protease inhibitor, and these drugs are available and FDA approved and have no effect on eukaryotic tissues, they only affect the virus, and these patients won't have the virus. So we will have a very specific way to convert the CAR into an immunocompetent, capable of signaling. And this is where you can see the full-length CAR. When you give the grazopavir is there, but if the grazopavir goes away, you lose that full-length CAR. Okay, so the first thing we wanted to test using this snip CAR is, could it serve as a safety switch? Because we know with the solid tumors, we need to take chances. We're going to have to go after some targets that have risk. And we're much better equipped to do that if we can control the CARs once we put them in. Right now, the B7H3 CAR that we're giving to our patients, it's a living therapy. We give it and it expands. And we can throw corticosteroids or other immunosuppressants in there, but we don't have a very adaptable way to control the CAR. So one of the things we wanted to learn is, could we use it as a safety switch? Can we just turn off a toxicity? So we had a toxicity model in the lab. This is some mice that die after they're being treated with a CAR targeting a completely different molecule called ROR1. And you can use bioluminescence in the mice and look for not only where your CAR T cells are in those mice, but where they're getting activated. So the bottom pictures here show where the cells are getting activated. So these CARs were getting activated in the lungs of mice that express this target. And here was our control, the CD19. And then if you take the lungs out, you could see, yes, indeed, here are these CARs circling around the lung. So this was now a toxicity model, and it allowed us to ask, can we use the SNP CAR if we get into trouble for toxicity, and if we stop the dosing? Will, at least in this case, the mouse be able to recover? And indeed, that was the case. So that was encouraging. But that's what we call a suicide switch. It's nice. It makes us feel more confident that we'll be able to control toxicity if we see it, but it doesn't necessarily make things work better. And so the other thing that Louis noted is, when he was treating these mice with this drug, and he was giving them the drug every day, he wasn't turning the drug on and off. He was basically giving full dose of the drug. He noticed that the SNP CARs worked better than the CARs that were constitutive, like the ones that we're using currently in the trial. So this is a model of medulloblastoma, which also expresses B7H3. Here's the SNP CAR. Here's the constitutive. The same in this neuroblastoma model. Here's another sarcoma model. And here in the leukemia, it was equivalent because the constitutive was curative. But it really made us step back and scratch our heads and say, why is this one more potent than if it's turned on all the time? And we took the cells out. We looked at the cells. They looked, like they had, been more. They preserved their features that are associated with potency. This is some of the markers that you can see on CAR T cells that are likely to be potent. And I think I'll go through this quickly, but just to show you that they proliferate more if they're able to be driven by the SNP CAR. So they were showing all these features of potency. This is another, very intensive analysis using single-cell RNA-seq. And it allows us to divide the CAR T cells into different subsets. And you can see that the SNP CAR really was creating lots of different subsets, whereas the constitutive was all glomming up here in pink. And it turns out that these subsets on the outskirts are all of the stem-like subsets. So this is the kind of thing that, as a CAR developer, you're saying, oh, I have healthier T cells when I'm delivering it with this platform. And about the same time, my lab had really come to understand that one of the problems with CAR T cells is we're basically hitting the cells too hard. They're firing all the time on all cylinders, and Mother Nature turns things off that are firing that much. And so what we've learned is if you can just shut things down, even for a short period of time, what the cell does is it resets itself, and it gets takes away this feature, what we call exhaustion. And so the cell is no longer exhausted, it becomes more potent, and that's what the SNP CAR was doing. So that was good. We had a more potent CAR. If we got into toxicity, we could turn it off, but could we really thread the window? Let's say with B7H3, where we know it's higher on tumor than it is on normal tissue, but it's still pretty high on normal tissue. So what Louis did was, instead of giving full dose of the grazopavir, he lowered the dose. He just said, if I give it enough of an on signal, but not a full on signal, maybe I can thread that therapeutic window. And indeed, what he was able to show is that indeed, if he gave lower doses of the grazopavir, he was able to cure the tumor without toxicity. And so we had, a situation here where you're trying to control, to regulate the activity of the CAR. If it's really firing on all cylinders and you have a target that is on normal tumor and normal tissue and tumor, you're going to kill both of them. But if you can tune it down just a bit, you can find a window where you spare the normal tissue and you go after the tumor. If you go too low, you miss them both. And so we think that these remote controlled CARs are, a really innovative way to regulate the activity of CARs. It can work as a safety switch, but it also seems to make the cells more potent. And we think it's because there's transient rest. Every time the drug gets cleared or it goes below the level of activity, it sort of cycles. And so we're hoping that we can use remote controlled CARs to make them more potent in the setting of ovarian, but also to get us out from under this problem of IECHS, which has been a real issue. So I guess I had an extra slide in there. But so we're pretty excited about being able to take this into the clinic, and Oliver is going to lead this in the ovarian space. Dr. Ramakrishna in the pediatric sarcoma space, and Alison Betoff-Warner in some of the adult epithelial space. And Alex Salter is a very talented MD, PhD, med-onc, who's going to be working on this. So it's an example of, how this fundamental research can lead to a therapeutic, but you find problems and you have to go back to the bench and rework it. And that's what we're doing. So this thing it's not a village, it's an army. You need so many people to do this type of work. I really want to note the Stanford GMP team, the regulatory team. Emily Egler is here. So much paperwork goes to the FDA. I mean, it's really amazing. And also just the brilliant folks in the lab, and Louis, whose brainchild this was. I want to echo the thanks to Alan and Irene Adler. Without them, we wouldn't have been able to launch this cell therapy program in ovarian. You need to be able to invest in this for the long haul. Rarely do you win right out of the gate, and you need to kind of be persistent and iterate. And then also, both the Alliance for Cancer Gene Therapy and the Troper Wajicki Philanthropies have supported our work on the SNP CAR. Thank you very much.
Thank you so much. That was a wonderful talk. Does anybody have any questions?
Thank you. Excellent work. What about pulsing in lower doses of CAR T instead of giving all in one dose?
Yeah.
Fractionated.
Cell therapy, one of the allures is that it's a living therapy that lasts. When CAR T works in myeloma and in leukemia, it persists for months, even years. So we try not to think of it like a drug, because the power is really the persistence. The drug is more like the ADCs. Now, that said, we're starting to see people use things like lipid nanoparticles to deliver some of this genetic load. In that case, it would be more of a drug that you would pulse. But these living therapies, It's very expensive to make them. You're not going to make multiple doses and just go in and kill
But
them.
those living cells are getting exhausted.
Yeah.
So why not give them
Give them more.
boost?
We actually do give multiple dosing in the brain. One of the problems is you sensitize. They likely sensitize and reject. It's complicated.
Thank you.
Oliver.
Can I ask a question?
Yeah.
Let's say we translate this to the clinical trial. I would be very excited to try this. How do you titrate the drug, given that the cells are expanding? Would you not think that over time, as they expand hundreds, thousands of cells, you will have to give more drug to chill the car?
This is a very well tolerated small molecule. So the KD, you don't need much of it to turn this thing off. So I don't think we'll get saturated, and I don't think the cars will outstrip our ability to saturate because we can drive it up to micromolar concentrations. But it does raise an interesting question of the clinical trial design. Right now we're thinking we keep the drug constant and we escalate the cell dose, but of course, at some point, you're going to want to modify the car dose. I mean, the drug. I think the PI looking at the patient is going to eventually, this is what I imagine, that in the future, we'll be able to remotely control these little machines that we're putting in. And each patient's going to be a little bit different. Some patients are going to say, Doc, I want to take more. I'm feeling pretty good. Let's drive these things. Somebody else is getting sick and their fibrinogen is dropping and their liver enzymes are up. Let's just, give you a little drug holiday for a few days. So I think there's going to be a lot of personalization.
Thanks. So interesting.